4557. For whatever reason, there's a typo. The number 6 does not appear, but it should appear. I do not have any pictures that will be appearing on your test. Mine will all be word questions. And the reason I'm going a little fast is that I need to get through 17 items and let Dr. Vila have some time, because you all have an 11 o'clock, correction, 11:10 class after this. Okay. Okay, this is the first item that's on your list. You have the section in your notes it's all about. When you read your notes, be very be sure to understand that the reticular nervus and the underlying subcutis, and that's what we're talking about here, the reticular nervus and the subcutis. They're altered association with systemic diseases that manifest in the skin. And when we talk about systemic diseases, one of the diseases which we studied was rheumatoid arthritis. And you look at your notes, where do the rheumatoid arthritis nodules form? If you look at your notes, you'll see that they actually form in the subcutaneous or the cutis. And then note that the papillary nervus with its vascular plexus and the epidermis, they usually react together to diseases that are primarily limited to the skin. And the best example of this is psoriasis, where you basically have the changes in the epidermis that you're about to discuss. And remember, we're talking about squirting the blood, but you don't have any changes below that. The second item, microscopic terms, is very simple. This is in your notes when you have the definitions. One of these terms, the definition will appear, you tell me what the term is. The third item, you'll be given a clinical presentation, and you have to select the diagnosis. And you'll have to understand, I would say it, have a good understanding of psoriasis, and how a patient can present with chronic plaques, which show a silvery white scale on the surface of the erythematous plaques, and it's normally on extensor surfaces. And when these scales, these white scales are detached, you have a little pinpoint foci of bleeding that dotted, and if you know from the class, I was telling you that these are the papillary blood vessels that you've uncovered when you take off these silvery scales. And that's called Osgood sign. And the other thing is that when you get a biopsy of psoriasis, there are 3 elements. You'll have hyperkeratosis, you'll have parakeratosis, and you have acanthosis of the epidermis. Those are characteristics of psoriasis. And the last thing is that ocular findings. Now, these ocular findings in psoriasis are non-specific. They occur in approximately 10% of patients. The most common ocular symptoms are redness and tearing due to conjunctivitis or blepharitis. Item 4, you'll be giving a clinical presentation in which you'll have to select a diagnosis. You'll have to be familiar with bullous pemphigoid, and you remember that we talked about plaques. This manifests by multiple tense bulli. If you remember pemphigus vulgaris, which is what we said before this, it has flaccid. Bullous pemphigoid has tense. And we also talked about the fact that when you look at the blister will basically have nearly the entire epidermis as the roof, and the basement membrane zone, specifically the lamina lucida, forms the bottom. And here we do immunofluorescence staining. The antibodies will basically light up in the lamina lucida, which is along the basement membrane zone. If anybody has any questions on one of the class, don't be afraid just to speak up. Otherwise, I'll just quote it. Now, item 5, you got to know the role of ultraviolet light and sun exposure and skin conditions. And basically, what it is that I've given you these 5 citations. And if you look at these, 4 citations, the first citation, when you look at this comparison of cutaneous and ocular melanoma, what you should know is when we talk about UV light as a risk factor, it's well supported for cutaneous melanoma. It is uncertain for uveal and petroclival melanoma. And when you look at basal cell carcinoma usually develops on sun-damaged skin of people with fair skin and freckles. And likewise, but don't be thrown off by the fact that sun does play a role in basal cell carcinoma. Don't be thrown off by the fact that there is some basal carcinoma that does occur on areas not exposed to sunlight when you still trying to figure out how that happens. And finally, squamous cell carcinoma, the citations you'll read is that it has multiple causes, ultraviolet being the most common. So, and one of the things that I included in your handout that is not in your notes, but it's information you have to know on the test, and I assume you already all know this by now, is that UV light does underlie that people get sunburns. Item 6, which this is the one that was labeled 5 on your notes, and was added to item 6. Basal cell carcinoma, you'll be given a clinical scenario, and you'll be given a description of a curly papule, which is a prototypic nodulocystic lesion, because it resembles a 2 to 3 millimeter pearl. It is covered by tightly stretched epidermis and laced with small, delicate branching vessels known as acacia, and this basically is the presentation of what I just described. Then we went into the musculoskeletal system. Regarding osteoarthritis, I want you to know the descriptions and terms used in describing the pathology of osteoarthritis. And basically, this is the paragraph that's on the slide and is also in your notes. In early osteoarthritis, you basically get the chondrocyte proliferation forming clusters, which is called cloning. What I'll be giving you is that I'll be giving you a clinical scenario which defines one of the characteristics of osteoarthritis, and you may have to tell me which of the characteristics is it. Is it cloning? Is it the fact that the chondrocytes die, they dislodge, and become loose bodies or joint mice? Is it the fact that when you expose the bone in osteoarthritis, the new articular surface basically starts with friction on the opposite bone, and this gives it a polished ivory appearance, which is called eburnation? Or is it the one-way small valve mechanism that causes the subcondylar cysts, which I'll be showing you a picture in a minute? Or is it the mushroom-shaped osteophytes, the bony outgrowths that develop in the margins of the articular surface? Once again, if you're looking, this shows you that the articular surface is worn down. This is bone. When this bone rubs against bone on the opposite side, this causes eburnation. You have the bony osteophytes that can form here, and you have the cracks and fissures. You have the cloning. So know all the terms and definitions we just covered up. And this is another example of the bony eburnation and the subcondylar cysts that form in osteoarthritis. Item 8, we're talking about rheumatoid arthritis. You got to know the characteristic histologic features of the major morphologic manifestations found in joints in rheumatoid arthritis. And basically, this paragraph right here, which is in your notes, 4 of them will be altered. 1 of them will remain true. You have to know the characteristics of how rheumatoid arthritis presents. And remember, these 5 characteristics actually together, they cause the change, the pamus, that inflamed synovial tissue, which is characteristic of rheumatoid arthritis. Item 9, ocular manifestations of rheumatoid arthritis. This is out of your notes. Know this paragraph, or actually this entire section is in your notes, because 2 questions come out of this one. Both of them about the ocular characteristics. You know, we talk about one thing, keratoconjunctivitis. You all know that another term for that is dry eye syndrome. And you know about its association with Sjogren's syndrome. Sjogren's syndrome is also associated with rheumatoid arthritis, among many other syndromes. But keratoconjunctivitis is the most common ophthalmic manifestation of rheumatoid arthritis. Then we talk about episcleritis, and we talk about scleritis, that can form in arthritis, rheumatoid arthritis. And I want to bring your attention to the necrotizing scleritis. This is a destructive scleritis, which doesn't have inflammation. The patient will not have pain. It's also called sclerotia perforans. It's characterized by a severe thickened sclera and an otherwise normal, clinically uninflamed and painless white eye. Once again, keratoconjunctivitis sicca. If you stain the eye, you'll basically see the devitalized surface cells. No, and necrotizing scleritis and rheumatoid arthritis, basically, this is the way that lesion looks. Item 11, gout. You have to understand the 4 clinical stages of gout, and given the description, identify the clinical stage you need to describe. In your notes, I describe in detail these 4 clinical stages of gout. We talk about asymptomatic hyperuricemia, in fact, in puberty, and many, especially males, will present with a high uric acid. Now, remember, having hyperuricemia is not necessarily guaranteed that someone will go on to develop gout, but it raises the risk that he or she will. We talk about acute arthritis. This is acute gouty attack, the pain, normally monoarticulate, that will normally bring the patient to the physician. Then we talk about that asymptomatic intercritical period, where everything seems to quiet down. And then after 12 years, you get chronic facious gout, where radiographs will show the characteristic juxtaarticular bone erosions caused by the osteoclastic bone resorption and the loss of the joint space. And one thing, oops. I'm sorry. There's a slide that I believe I did. Item 12, gout versus pseudo-gout. The two sections which I gave you here, if you read this will describe to you what the crystals in gout are described as. They're sharp, they're needle-like, they're found in the cytoplasm of the neutrophils, and they're negatively birefringent. And then this section will talk to you about the crystal-induced arthritis, specifically the subsection on calcium pyrophosphate crystal deposition, which is called pseudo-gout. And these are rhomboid. They tend to be pale blue in color. They tend to be positive birefringent. So know those, read and understand the difference between crystals, because once again, I'll give you a description and ask you to tell me what is the characteristic of a specific type of crystal. Item 13, myasthenia gravis. I'll give you a description, identifying the musculoskeletal condition, identifying a specific musculoskeletal condition or disease, and you've got to tell me what it is. In this case, it's myasthenia. You'll remember, myasthenia is an autoimmune disease, and that it has two autoantibodies that are involved in it. 85% of the autoantibodies are the antibodies against the acetylcholine receptors. And remember, in class we talked about the fact that in myasthenia gravis, basically what you see is you basically see a loss, a degradation of these receptors, of the acetylcholine receptors, and you see damage of the postsynaptic membrane that occurs because of complement fixation. And we also talked about the fact that myasthenia tends to have a high association with thymic abnormalities. Approximately 10% of the patients will have thymoma, and approximately 30% of the patients will have thymic hyperplasia. Then ocular myasthenia gravis. I'll give you a clinical scenario of the patient, and I'll ask you to, what is the appropriate serological testing for this presentation. Now, if you have a patient who has ocular myasthenia gravis, the way you confirm that is by obtaining a positive acetylcholine receptor antibody titer. And this is, once again, taken straight out of your notes. You actually have two questions on ocular myasthenia. And what I'll do is I'll give you a list of descriptions. And you have to identify the description which is accurate. And once again, what this paragraph, which is actually the same as what I just showed you, read it and understand it. Because once again, 4 of the statements I will make from this paragraph will be false. 1 will be true. You have to know which one is true. Finally, 16, Duchenne muscular dystrophy. I'll give you, 16, then go to 17. I'll give you a clinical assertion. You identify the musculoskeletal system. Remember, when we talked about Duchenne and Becker muscular dystrophy, they're both X-linked, and dystrophin plays an important part in both of them, and I'll cover that in a minute. But when we speak about specifically about Duchenne's, boys with Duchenne muscular dystrophy, they're normal at birth. But what starts happening is that they'll miss very early motor milestones. Rather, their very early milestones will be met, but their walking is often delayed. And you have this, if I'm not mistaken, this is right out of your notes, and it's also have the slide in the slide set. The first indications are muscle weakness, are numbness and inability with peers. The weakness begins in the pelvic girdle muscles and extends to the shoulder girdle, and the outer sign is simply the fact that when a child has this, has to get up, he or she basically will will use the strength of their upper extremities and actually push up of their lower extremities in order to be able to stand up. And also you see in the child that they tend to have a pseudo-hypertrophy of the calves. The problem with Duchenne's is the mean age of wheelchair dependence about 9.5 years, and these patients tend to die between the age of 25 and 30. And we talked to you about the dystrophin staining and the fact that this is what normal dystrophin staining looks like. See this dark brown color here. In a patient with Duchenne's muscular dystrophy, you have total absence of the dystrophin, and that's why there is no staining. That is as to distinguish it from Becker's, which has partial staining because you have a partial presence of dystrophin. So you will be given also a clinical scenario on Becker's muscular dystrophy, and once again, this is to show you the reduced staining. It's present, but it's reduced. These patients do not have as severe a course as Duchenne. They could potentially live an entire a normal lifespan, but realize in your notes, I also talked to you about the fact that dystrophin is also found in cardiac muscle and is also found in the CNS. And the absence, whether it's partial or complete, can cause cardiac problems in both of these patients. So if you have a patient who's in his or her mid-40s and they're jogging and they come in because of lightheadedness, you do an EKG on them, and they have an EKG, they have a dysrhythmia, and findings consistent with a cardiac myopathy. You look at their medical records, and they've got partial staining for dystrophin. This is basically a patient who has Becker muscular dystrophy. Why would it not be Duchenne's? Partial staining is one. This is a patient in the mid-40s. How long do Duchenne muscular dystrophy patients live? Right, 25 to 30. And so, when you're all in this phase right now, does anybody have any questions or anything which I presented? Okay, thank you for your time. Let me just